Hi, everyone. Good morning and welcome to our Friday morning seminar. Today, we have a fascinating session with a lecture by Dr. Robert Flavell on the topic of thyroid cancer imaging update. Dr. Flavell, an MD and PhD, is an associate professor in the section of molecular imaging and the Department of Radiology and Biochemical Imaging in the University of California, San Francisco. He received his medical degree from the Weill Cornell Medical School and PhD from the Rockefeller University as part of an MD PhD program. He completed his internship in Memorial Sloan Kettering and then completed a 4-year diagnostic radiology residency at UCSF, where he also completed a nuclear medicine fellowship. In 2016, he joined the faculty as an assistant professor, and since 2019, he serves as the chief of the Division of Molecular Imaging and Therapeutics in the Department of Radiology and Biochemical Imaging. Dr. Flavell Laboratory focuses on the development of new molecular imaging methods and therapeutic tools for better detection and treatment of prostate, thyroid, and other cancers. So Dr. Flavell, thank you for joining us, and the floor is yours.
Thank you very much for the kind introduction. Okay, thanks so much for the introduction. The title of the lecture today is Thyroid Cancer Imaging Update, covering kind of a broad range of territory here. I'm going to start with some material that's a little bit more basic, and that there's, as the lecture kind of continues on, we'll get into more specialized and, research content as well towards the latter part of the lecture. Okay, so disclosures, I disclosed some prior grant funding from Fukushima, SIC. This is a project not related to this lecture, so none of the disclosures are relevant to this particular lecture. Okay, in terms of the overall introduction, so radiology is an integral part of modern medicine. In no area is this more important than oncology, and imaging allows us to see inside the body, detecting abnormalities, underlying symptoms and diseases, and lets us monitor response to therapy. And in particular, in thyroid cancer, with advances in ultrasound, cross-sectional, and molecular imaging, radiology plays a key role in the management of thyroid cancer patients. So for the outline for today's lecture, we're going to start by reviewing the development of oncologic imaging and illustrating key differences between structural, that being ultrasound, CT, and MRI, versus functional imaging, nuclear medicine, and PET. Admittedly, the lecture is biased more towards nuclear medicine and PET imaging because that is my area of specialization. We'll describe the role of imaging in changing care in patients with thyroid cancer. We'll talk about selection of appropriate imaging modality, including the appropriateness criteria for selecting the right exam for the right patient. We'll talk about methodology in radioiodine and related molecular imaging technologies. We'll look at FDG PET-CT, which of course is the standard type of PET-CT exam widely used across oncology. And we'll talk about molecular imaging of targets beyond the sodium iodide symporter, which is the target for radioiodine imaging, and the glucose transporter, which is the target for FDG PET-CT imaging. So here's just a little bit of a historical perspective on the development of imaging in cancer with the focus on the structural imaging modalities. So chest X-ray, of course, developed in the earlier part of the 20th century, remains a mainstay of clinical management for a variety of different technologies, not really used so much for staging and restaging of cancer patients these days, but still an important role in medicine, and detects differences in attenuation. And here's just a characteristic appearance of a patient with lung masses, probably from metastatic disease. And that remained standard for many years. In the 1970s, this was advanced into a technology called computed tomography, or CT scan. This produces essentially a three-dimensional map of attenuation. So here's an example of a patient with a lung cancer, in this case, in the right upper lobe. And more relevant to thyroid cancer, of course, is the use of contrast-enhanced CT imaging in the neck. In this case, the contrast-enhanced gives you better soft tissue visualization, allowing you to distinguish things like, lymph nodes, benign thyroid tissue, and vascular structures, etc. course, in thyroid cancer, there's an important use of methods outside of X-ray attenuation, and none really is more important than the use of ultrasound, originally developed for clinical use in the 80s and 90s. Here's a, just classic example of a, papillary thyroid cancer. This is sort of a, just enlarged thyroid nodule, this sort of non-specific in appearance, but, not an atypical appearance for a thyroid cancer that may either be incidentally detected at thyroid scintigraphy or detected as part of, physical exam or normal clinical management. Another technique that plays an important adjunct role in thyroid cancer imaging is magnetic resonance imaging, or MRI. So this was originally developed for clinical use and really more in the 1990s. We can see here an example of, patient with thyroid cancer. Again, similar region here, right side of the neck. And the way MRI works is primarily based on the intrinsic magnetic properties of the tissue. So these techniques that I've talked about so far have features in common. What they are seeing is alterations in tissue structure. And however, one thing that's been known is that changes in metabolism or tissue function often become before gross alterations in tissue structure. And for this reason, metabolic or functional imaging can be more sensitive for detecting or following response to treatment in thyroid cancer. And as part of standard of care in thyroid cancer management, we routinely utilize functional imaging with iodine 123 or iodine 131, and PET imaging with F18 FDG. And this is routinely used to detect, characterize, and monitor response to therapy in this disease. So one of the things I do as part of my job is cover the thyroid tumor board at our institution. And one of the more frequent questions I get is, what scan, should I order next for this patient to work it up further? So there really is no universal answer to these questions, but and there's often a lot of ambiguity, but I can go through some of the more common scenarios and provide some of the guidelines that may help in your decision about what is the right scan to choose for the right patients. In terms of just broad trends, the methods that do not use ionizing radiation and are less expensive are great for the frontline testing. And really in thyroid cancer, there is no better first test for evaluating the neck than ultrasound. More advanced imaging can be called into play for higher risk scenarios. And in particular, more advanced imaging is helpful for guiding treatment planning. So for example, CT or MRI is really great for planning surgery, since it gets you really a nice look at where the cancer is related to normal tissue, so that can help the surgeon plan, is there involvement of the recurrent laryngeal nerve? Is there involvement of the vasculature, strap muscles, et cetera? And then similarly for planning radioactive iodine therapy, iodine 123 imaging is really an essential part of it, helps guide the pretreatment decisions. And then FDG PET-CT can be particularly helpful for planning treatment for a suspected aggressive or widespread metastatic thyroid cancer. Okay, one of the useful resources, if in doubt here, is the ACR appropriateness criteria, or American College of Radiology. They have a few that are relevant to this. I think they're generally, I agree with most of these recommendations. So just to hit some of the highlights of the key ones here. So for preoperative imaging in differentiated thyroid cancer, really the frontline testing should be ultrasound of the thyroid. As I mentioned, no radiation, pretty readily available. And then another good one to use in this indication is CT scan of the neck with contrast. As I mentioned, it gets you great differentiation of the soft tissues from the cancer, et cetera. Other ones that may also be considered is, non-contrast CT and MRI. Those are reasonable alternatives. Just the one thing to note, of course, about ultrasound, it is quite operator dependent. So depending on institutional expertise, you may rely on it really almost entirely for management of your thyroid cancer patients with respect to the neck, or if you're in a location with perhaps less expertise to specialized sonographers with expertise in thyroid cancer, you may want to rely more on the other techniques, CT, MRI, et cetera. So after surgical resection for differentiated thyroid cancer, for early monitoring for recurrence, again, thyroid ultrasound, really the frontline testing in this scenario. Beyond that, there's a variety of different techniques that may be considered. And I think these are all reasonably choices. There may be some differences based on institutional preference. So iodine 123 whole body scan or iodine 131 whole body scan for looking for sites of recurrent or metastatic disease. And then again, CT or MRI of the neck as well with IV contrast. As we progress into kind of the higher risk scale for patients who have actually not just routine monitoring, but for suspected recurrence, probably more routine use of this multimodality and advanced imaging is more appropriate. So CT is scan of the neck with IV contrast, ultrasound of the thyroid, whole body scan, and MRI of the neck, all reasonable tests in this case. And if those don't answer the question, then you can kind of go into these second line tests. So CT scan of the chest to look for lung metastases or whole body PET CT if you're suspecting like a dedifferentiated thyroid cancer. Okay, so that's it for the section on which imaging modality to choose. So now let's get in a little bit more in depth on radioactive iodine imaging. So how does this technology work? So the major function of the thyroid gland is to make thyroid hormone, and this sets the metabolic rate for many essential functions in our body. The thyroid uses iodine as an essential element for making T3 and T4, called thyroid hormone, and well-differentiated papillary and follicular thyroid cancers retain this property. So what this means is that tracer doses of radioactive iodine can be used for imaging and treatment of these thyroid cancers. And it's important always to remember that this particularly applies to differentiated thyroid cancers, papillary, follicular, et cetera. And then other types of thyroid cancers, such as medullary, anaplastic, and poorly differentiated thyroid cancers do not take up radioiodine. So this scan is not indicated in those patient populations. So I think it's interesting to note that radioactive iodine treatment with iodine 131 was developed before the capability to image it, and that the imaging really came later on in the 1950s, 1960s, and has evolved, as I'm going to show a little bit later on in the lecture. So this is interesting. This is actually, the first description of the use of radioactive iodine for treatment of thyroid cancer patients. You can see here in this patient, here's a X-ray of their pelvis from this 1946 paper. Don't see too much going on in panel A. Then in panel B, we have this lytic lesion that's kind of eroding into the acetabulum here. This patient was subsequently treated with radioactive iodine, and then you can see that there's a healing response here. There's increasing sclerosis, and the metastasis is shrinking. So let's talk a little bit about the details of the methodology of how radioactive iodine imaging may be performed and optimized. So iodine 123 is what we use at our institution for diagnostic thyroid whole body scan and SPECT imaging. So this is a cyclotron-produced isotope. It has a 13.2-hour half-life. It decays by electron capture and has characteristic emission of 159 keV gamma ray, and that's what we're imaging with our scanners. It's typically administered as a pill with a dose of 1 to 2 millicuries. And the imaging technique typically includes 24-hour uptake. The 4 here is used also more for hyperthyroid patients, so it's not as relevant to the thyroid cancer setting. And then imaging is performed at 24 hours with whole body scan with gamma camera, with or without SPECT or SPECT CT. Iodine 123 is used for diagnosis only and is considered to be the optimal method for diagnosis, but the main limitation is a high cost compared to the alternatives. One thing we have observed, and perhaps if some of you are specialized in this field, you may also have observed intermittent shortages of this since COVID started. So we've had some patients where we've not had the availability of iodine 123 for our diagnostic scan, and we've had to use some iodine 131 instead. So iodine 131, of course, the classic one, and what I showed you from that 1946 paper, uses a therapeutic isotope as well. So iodine 131 is produced in a nuclear reactor, has a half-life of 8 days. It decays by beta emission with subsequent decay and emission of a 364 keV gamma ray. It's administered PO or as pill or IV as needed. So typical dose for a diagnostic scan is 2 millicuries. We'll get into the treatment doses a little later on. The imaging technique for a diagnostic scan typically includes 48-hour planar imaging with gamma camera, whole body scan, and SPECT or SPECT-CT. It is used for both diagnosis and therapy, and it is less expensive than iodine 123, but it is a higher radiation dose, and that because of the higher energy of the gamma rays that are produced, it has suboptimal imaging properties and creates characteristic artifacts. Just one thing to note about iodine 131 is while it's not ideal for imaging, it should absolutely be obtained routinely in patients undergoing therapy. So it should be routine to perform post radioactive iodine therapy scanning to determine presence or absence of residual or metastatic disease. Another interesting note about iodine 131 is it is a major environmental concern for nuclear disasters. So if, case of nuclear meltdowns and release of waste from reactors, it can result in significant emission of iodine 131 into the surrounding environment. This is why, typically around the time period of nuclear disasters, there's, a run on the use of iodine 131 pills, or not iodine 131, regular iodine pills, potassium iodide for blocking the thyroid gland. So what do these images typically look like? So here's some very, classic and typical appearances you'll see. So this is radioactive iodine imaging in a patient with lymph node metastasis. This is planar only imaging, the real classic strategy. So we can see here kind of the typical uptake in the neck, and then a lymph node metastasis in the upper neck. One thing to note, and one of the key points I want to highlight in this lecture, is that SPECT-CT increases sensitivity and specificity of radioactive iodine imaging. So here's a nice example of one pulled from a publication. So here we see 2 spots present in the neck on the whole body scan. And then, looking at the CT, it seemed, and overlaying them on the CT, what we can see is that the spot over here on is more in the midline and consistent with the thyroid bed remnant, whereas this one here is located at a little bit more laterally, correlates to the small lymph node, is consistent with the lymph node metastasis. So really quite useful to help us differentiate between those things. And the real advantage here is kind of the use of hybrid imaging, where it's being fused together with CT scan. And in general, if a SPECT scanner is available at your institution, I would recommend that it is used routinely for patients with thyroid cancer. So is there evidence to support what I'm saying here? Is yes, there is some, and really the key kind of biological basis of the advance is the improvement in anatomic localization. So that allows more improved delineation for benign things. So for example, uptake in the esophagus or central thyroid bed versus malignant. So i.e., uptake in a bone metastasis, a lung metastasis, or lymph node. The downside of using SPECT-CT is that it does have increased cost and a slight increase in radiation. So just a couple papers, kind of classic, that prove the benefit of this technology is that post-therapy SPECT-CT reduced the need for further imaging in 20% of patients and significantly altered risk estimates in about 6% of the patients. And then another paper here, 13% of patients had equivocal foci on imaging on the whole body scan, which were characterized as definitively benign on the SPECT imaging, and had more precise localization to skeleton for bone metastases or lung for lung metastases versus mediastinum in 6% of the patients. So here's an example from our institution. So this is a patient looking at the whole body scan. We see a few different foci of uptake, central neck, and then another spot down here lower on in the chest. So looking in the neck, we have the couple kind of classic appearance of thyroid remnants, kind of thyroglossal duct here in the top left, and then central thyroid bed as well down here below. And then we found an additional spot of uptake here in the anterior mediastinum in this patient, again, suspicious for lymph node metastasis. Of course, without the SPECT-CT, it'd be much more difficult to localize where that focus of uptake is, probably necessitating, additional imaging subsequently to figure it out. Another nice example of a classic artifact that we see here. We have some uptake seen here in the neck. If you don't have access to SPECT CT, the best next maneuver here is to have the patient drink a glass of water and hopefully clear it out. This is very easy to solve with SPECT CT as well. You'll just see that the uptake correlates with the esophagus. Another nice example here of the use of SPECT CT. So on the left here, we have whole body scan. When I describe these sorts of scans to my resident, I like to kind of make analogies to images of outer space, right? It just kind of looks like, maybe a few asteroids or stars floating out there somewhere in the galaxy. You can't really tell much of where anything is. But then, of course, if you fuse it on top of the SPECT CT, it becomes, very simple, right? And then these spots down here turn out to be bone metastases here in the lumbar spine and then in the right pelvis as well. Nice example, 3 spots in the neck. What does each spot correlate to? So here we have one kind of up here in the region of the lacrimal duct. So this is physiologic clearance of, secretions from the lacrimal gland. Uptake here in the anterior central neck. So thyroglossal duct remnant, again, a physiologic variant commonly seen in many patients. And then the bottom right here, central thyroid bed remnant. And then as a contrast here is a nice example, again, pulled from the literature. So some additional foci seen here in the neck, looking at the SPECT CT, these are clearly now localized more towards the lateral neck, and these are consistent just all with lymph node metastases in the lateral neck compartment. So now that we've kind of gone through the methodology and the use of these imaging techniques, let's talk a little bit about the role of imaging in radioactive iodine therapy. So the traditional approach used for thyroid cancer at our institution and at many others as well. So is the fixed dose approach. So different categories of patients. Outside the scope of this lecture to really go through this in detail, but typically for remnant ablation patients, a range from 30 to 100 millicuries. For adjuvant therapy, 100 to 150, and for tumor therapy for metastatic disease, typically 100 to 200 millicuries. Pretreatment imaging with iodine-123 whole body scan and SPECT is useful to identify unsuspected mets and large thyroid remnants. The advantages of this dosing strategy is that it is straightforward and generally effective for patients, can be routinely implemented in centers throughout the community. The disadvantage of this sort of strategy, particularly if you're going into the higher dose or patients with comorbidities, is that it may overdose patients with renal failure advanced stage, and it may underdose patients with aggressive disease. So an alternative strategy here is the use of dosimetry, where you're optimizing the radioactive iodine therapy through the use of imaging. There's 2 classic approaches for thyroid dosimetry. The first is called the bone marrow dose limited, or sometimes also called maximum tolerated activity, or MTA approach, versus lesional dosimetry. So in lesional dosimetry, this is using imaging, generally iodine-124 PET, to deliver predicted doses to tumors. And in the bone marrow dose limited approaches, the goal here is to deliver the maximum safe dose to not incur damage to the bone marrow. And that's calculated typically as 2 grade of the blood based on early safety publications from the latter part of the 20th century. So the advantage of this bone marrow dose limited approach that I'm talking about, where the goal is to identify the maximum safe dose, is that it may allow higher doses of iodine-131 in some patients, and it also identifies patients where high doses may not be safe. However, the disadvantages of these dosimetry strategies is that while the benefits of it is plausible based on the biology and rationale, there really is no strong randomized clinical evidence to provide a benefit over a fixed dosing approaches. This does require more complicated pretreatment imaging scheme. And in some cases, if you're administering very high doses, may require admission to the hospital, resulting in more patient inconvenience. So there's some controversy in this area of dosimetry, and interestingly, there's no standardization of approaches across the institutions. I set this up at my institution a few years ago, and when speaking with various people where they're implementing at their centers, I realized that there are no 2 protocols that are the same. There's absolutely no standardization whatsoever. It does require the expertise of an in-house physicist to help you set it up. And I thought this was interesting. Doug Van Nostrand recently performed a survey demonstrating several facilities domestically and internationally who do perform it. And this information about thyroid dosimetry is available online at the Society of Nuclear Medicine and Molecular Imaging. And it is a worldwide map. So if you're interested in learning about centers near you that are performing thyroid dosimetry of various types, you can go to this website to check it out further. So the technique for MTA dosimetry that we use at our institution is we perform pre-treatment scanning with 2 millicuries iodine 131 with 2-hour, 48-hour, and 72-hour whole body scan. We perform SPECT CT at 48 hours. You could argue that you could perform SPECT CT at all the time points. It just becomes very long scan and very camera intensive if you do that. The whole body activity gets fit via nonlinear regression and converted via MERD methodology to estimate an effective radiation dose. And the ways that the rules that we kind of set for maximizing our dose is ones that result in less than 2 gray to the bone marrow, less than 120 millicuries the whole body at 48 hours, or 80 millicuries for lung metastases, and not more than 250 millicurie total dose. This is really based on classic publications from Benoit and Leeper, and this approaches or variations of this sort of approach are used pretty widely. And then we review the images and we discuss them with our endocrinologist, deciding our final dose, and then we administer the maximum tolerated dose with appropriate precautions. We arbitrarily set a limit of 250 because that means we are going to be able to release the patients. If you at our institution with our rules, we've kind of said if you start going above 250, you may have to admit the patient to the hospital as well. So we've decided not to go for that for now. So here's just an example that from a recent publication from our institution. So how are we doing it? So multiple time point imaging, 2 48-hour and 72-hour images. So you can see the earlier 48 and 72-hour images. You can see that there is quite a bit of uptake that this patient's having in their mediastinum and hilar lymph nodes, so consistent with lymph node metastases. So the whole body retained activity, which was shown here in the counts below, was fit to time activity curve and converted via MERD endorsed methodology. MTA was calculated at 33.9 gigabecquerels, which is very high in MTA, right? So we did a lot less than that because, as I mentioned, we're doing the safe outpatient discharge, 250 millicuries. You could, the data shows that you could safely administer much higher doses, but we're, for the patient convenience, we're not doing that right now. There are some advances in technology. What I've described so far really is just actually quite an old technology, right? It's based fundamentally on gamma camera and SPECT imaging, which was originally developed in the 1960s, 1970s, SPECT and SPECT CT more like 90s, 2000s. But there are other imaging methods that have been used and some that have been more recently reported that may actually be more sensitive for detection of thyroid cancer and targeting that sodium iodide symporter. So a nice example of this is Iodine 124 PET, a nice publication here from a few years back comparing the sensitivity of a diagnostic Iodine 124 PET scan versus post-treatment Iodine 131. So Iodine 124 emits positrons, and the advantage of that is that it can be detected via positron emission tomography and CT scan. I'll show the physics that underlies that in a couple slides to come. So when comparing Iodine 124 and Iodine 131, there was an improved sensitivity of 92 versus 70%. Here's a little bit of the more information about the physics for those of you who may be interested in the topic. But however, Iodine 124, even compared to other positron emitting isotopes, is expensive, and it has a suboptimal emission profile. It does produce very high energy positrons and a lot of other radiation as well. So it's not ideal. It's also not FDA approved and not widely available, certainly in the United States. Really only a few institutions currently using this, but it has some nice applications in dosimetry. So this is the lesional dosimetry that I was referring to earlier. And in this case, what you can do is you can perform the scan, multiple time point scanning, and then Now, instead of just fitting the whole body activity to the curve, now you can fit each individual lesion activity to the curve. And then based on that, you can prescribe a certain amount of radiation dose in terms of grade to an individual lesion. So most classically, this is done via multi-time point imaging scheme. Of course, multi-time point imaging is inconvenient for patients to have them come in, for 4 trips to the hospital, for example. And then some nice publications looking at reducing this. So one here from Jensen et al., which found that a 2-time point imaging approach, 24 and 96 hours, was sufficient to accurately estimate dose within 13% error. So bringing this a little bit closer into routine clinical use. And here, nice publication from Freudenberg et al., who used this imaging protocol in 28 patients with high-risk differentiated thyroid cancer to deliver 100 grade to all metastases without exceeding 2 grade in the blood. And interestingly, in this patient cohort, 25% of patients had their management changed by the scan protocol compared to standard treatment. So really some kind of promising evidence out there suggest that this may be a good technique for managing patients with high-risk thyroid cancer who you're treating with radioactive iodine. Another more recent technology that has been developed is F18-TFB, or tetrafluoroborate. So the way that this methodology works is this is an F18 labeled radiopharmaceutical, which is a substrate for the sodium iodide importer. So the same transporter that brings radioactive iodine into the cell. And it's the PET analog to pertechnetate, or which is used commonly in single photon imaging. And in this manuscript, these authors demonstrated that this has high sensitivity for differentiated thyroid cancer and is complementary to FDG PET. The reason to have some hope about this sort of technology is that it has high image quality based on the F18 physics. So you can see here just a nice figure here from the paper. Planar whole body scan, not really demonstrating anything in this circled region here. The TFB PET, you can clearly see these small nodules there. Looking at the imaging here, you can clearly see that there's these very small nodules in the central neck, consistent with tumor occurrences. And then one thing that was interesting here is they used the TFB PET and FDG PET in these patients, and that particularly the combination of the FDG PET and the TFB PET had really kind of the optimal sensitivity. So to summarize, for radioactive iodine and sodium iodide or NIS imaging, so in general, for diagnostic scanning, iodine 123 is preferred to iodine 123 based on the superior physics. Post-therapy scans should be routinely obtained after radioactive iodine treatment. This helps for risk stratification and for improving further management. SPECT-CT should be used routinely for localization, and it improves sensitivity and specificity. It allows you to differentiate benign versus malignant causes of radioactive iodine uptake. You can use MTA dosimetry to determine the maximum safe dose that you could administer to a patient with iodine 131, so that can help you optimize your radioactive iodine treatment. And then some areas that are particularly promising include the use of iodine 124. In this case, you can use it for sodium iodide symporter targeted PET imaging, which enables the use of lesional dosimetry to allow kind of a more precise and customized radioactive iodine treatment protocol. And then even more recently, new tracers targeting the sodium iodide symporter. So for example, F18-TFB demonstrate promise for improved sensitivity and specificity compared to these other agents. Okay, so that's it for the radioactive iodine and sodium iodide symporter section of the talk. Let's talk a little bit about other molecular imaging methods for thyroid cancer. So cancer cells have profound alterations in metabolism that let them survive in an organism that would like to destroy them. And one of the most classic changes is called the Warburg effect, after Otto Warburg. Picture is shown here of active scientist who kind of pioneered the understanding of this effect. And I like this quote I read from him, which is that cancer, above all other diseases, has countless secondary causes. But even for cancer, there is only one prime cause. Summarized in a few words, the prime cause of cancer is the replacement of respiration of oxygen in the normal body by a fermentation of sugar. Of course, these days we know cancer is quite a bit more complicated, but it really highlights the, the kind of metabolic addictions that many cancers may have. And of course, glucose is the prime fuel for many cancers in this Warburg effect. So one of the key advances made in the 1980s, 1990s, et cetera, was the use of PET imaging to evaluate different cancers. So glucose itself, challenging to image, doesn't, you can label it with C11 for PET imaging, but C11 is not the ideal isotope. It will be metabolized and gets exported from the cell, et cetera. In contrast, fluorodeoxyglucose, where the 2 position has been replaced by a fluorine atom, can then be used, and you can replace that fluorine with an F18, which can be used for positron emission tomography. One of the key advances here that led to the use of this was that development in camera technology of coincidence detection. So here, a positron emitting isotope is present, decays to a stable nuclide, and then the positron scatters. So the positron is the antiparticle from electron. So when those 2 particles meet each other, the positron and electron, they will annihilate, and they produce 2 511 keV photons, which will travel at about a 180-degree path opposite from each other. So we have a ring detector array around the patient, and it will detect these coincidence events when they both reach the detector at the same time. And then a lot of fancy reconstruction algorithms and things developed really primarily during the 1980s and 1990s, but even still, still innovations continually being produced today to develop improved methods for PET reconstruction and imaging. So one thing to note in thyroid cancer, and particularly in the use of FDG PET imaging, is something which can sometimes be referred to as the flip-flop phenomenon. And what this refers to is that there's a rough correlation where FDG uptake is inversely correlated with the uptake of another tracer, so particularly iodine 131 or iodine 123. So what's happening here? So well-differentiated tumors resemble the normal underlying tissue. They express cell surface receptors such as the sodium iodide symporter and take up iodine 131. However, dedifferentiated tumors lose this feature. They become more glucose dependent and hypermetabolic and display more of that Warburg effect that we were talking about earlier. So up here at the kind of high aggressive end of the scale, we have poorly differentiated tumors with an aggressive phenotype, which are resistant to radioactive iodine treatment. They have a lot of FDG uptake and little or no radioactive iodine uptake. And then down here at the other end of the scale, we have well-differentiated tumors that have an indolent phenotype and that are amenable to iodine 131 treatment. This is an area, of course, where imaging is playing an important role. In some cases, is differentiated between these types of patients. So when would you consider using FDG versus iodine imaging in differentiated thyroid cancer? Of course, FDG PET is an expensive exam that involves the use of a lot of radiation, so preferred to restrict it for patients where it's most appropriate. So as I've discussed earlier in the lecture, really iodine 123, iodine 131 scan is preferred for the differentiated thyroid cancers, and particularly to assist for treatment planning for radioactive iodine. So PET-CT is useful in patients with papillary thyroid cancer who have rising thyroglobulin levels and negative iodine scan, or have suspected radioiodine refractory disease. And this can help detect potentially curable recurrences. FDG PET-CT is also helpful in patients with selected histologic subtypes of thyroid cancer. So this includes Herthal, tall cell, and anaplastic thyroid cancers. So let's look at some case examples. How does this actually come into play in actual clinical practice? So here's an example of this flip-flop effect with well-differentiated papillary thyroid cancer. So this patient is a 35-year-old woman with a history of metastatic papillary thyroid cancer. On the left side of the screen here, we have this patient's diagnostic iodine 123 scan performed after thyroidectomy. This patient had, you can see, multiple metastases in the neck, and then as well as diffuse pattern of uptake in the lungs, consistent with diffuse pulmonary metastatic disease. Here's this patient's FDG PET exam. This shows what is essentially a normal biodistribution for FDG PET, with a lot of uptake in the brain, clearance in the kidneys and bladder. Don't really see any FDG uptake in those lungs or in the neck. So that's good news for the patient. So this means that this tumor is a more well-differentiated tumor. So this portends a good response to radioactive iodine. It's associated with a favorable clinical course. And the best next step for this patient would be to treat with radioactive iodine. What about the other side of the coin? So here's a 45-year-old man with a history of metastatic papillary thyroid cancer. This patient underwent an FDG PET-CT and demonstrates a hypermetabolic pulmonary metastasis, SUV max in this case, 28.6, so very intense uptake of FDG in this patient. Looking at this patient's whole body scan, they had no uptake on a recent post-treatment iodine 131 scan. So these findings suggest tumor dedifferentiation. This is associated with a poor treatment response and poor prognosis and the presence of radioiodine refractory disease. So in this case, this is a patient that probably would be less likely to benefit from subsequent treatments with radioactive iodine, and instead may consider alternate treatment modalities going forward. Okay, so now that we've kind of gone through your bread and butter routine scans, examinations, used a couple techniques I wanted to highlight that can be used in thyroid cancer patients, or at least are currently being evaluated. The first is PSMA, or prostate-specific membrane antigen, which is expressed on the vascular endothelium of thyroid cancer. And then somatostatin receptors are highly expressed on medullary thyroid cancer and some other differentiated thyroid cancers. And for these, dotatate PET-CT may be helpful for these indications. For time reasons, I'm not going to be able to go through that, the somatostatin receptor, but I'd be happy to take any questions on that afterwards if there were interest. So briefly, let's go through PSMA, which is a theranostic prostate cancer target. So this is a cell surface antigen that's highly expressed on prostate cancer. It may be targeted with a variety of different targeting vectors, such as antibodies or small molecules, which are predominantly targeted against this extracellular enzymatic domain. Imaging and therapy is possible. If you either target something that contains a diagnostic imaging isotope, or alternatively a therapeutic isotope, or even non-radioactive treatment. One interesting feature that was discovered during the development of this for prostate cancer is that it is expressed highly on the vascular endothelium on a lot of other cancers, so including thyroid cancer. So there have been, I would say, a few different studies of this in thyroid cancer. Here's the different modalities that are treatment modalities that are used. They primarily use this urea targeting, this urea based scaffold here that targets specifically the PSMA protein. And there's a variety of different ones that can have an impact on the affinity and delivery. The one that we use mostly at our institution for imaging is gallium PSMA 11, shown here in the middle right. And in the middle left is the PSMA 617. This is a therapeutic agent, which is often labeled with lutetium 177. Both of these agents are approved by the FDA for PET imaging and treatment of prostate cancer in the United States. So we conducted a pilot study to look at the role of PSMA PET imaging in thyroid cancer, and a few others have published similar studies. I don't have time to go through every single one, of course, in today's lecture. So here's a comparison in a couple patients of PSMA PET imaging versus FDG PET imaging. So over here on the left is the PSMA PET imaging. It demonstrates a characteristic biodistribution in normal tissues, including lacrimal, salivary, kidneys, some bowel, liver, spleen, and bladder. What we see here is some, fairly intense uptake in some mediastinal lymph nodes, which are essentially negative on the FDG PET exam. However, look in the same patient here on the FDG exam, they had a lung nodule, which was FDG avid. But then also here in the gallium PSMA, they had another not small little nodule you can see up here in the neck, which was not present on the FDG PET exam. So interestingly, some heterogeneity, some lesions visible on PSMA, some lesions visible on FDG. Here's another example on the right. Patient had a mediastinal lymph node and a rib lesion visible on the PSMA study, not visible on the FDG. Now, however, what we did find in our study was that the detection rate for PSMA PET was actually lower than FDG, 65% versus 95%. Some other investigators have looked at this as well. So in this case, they actually even used the PSMA treatment for thyroid cancer. So they studied, in this case, this was a very small study, 5 patients with radioiodine refractory differentiated thyroid cancer. They all went gallium PSMA PET CT. And based on the review of the scans, the 3 of the patients were deemed eligible for treatment with predominantly PSMA avid lesions. 2 of them got treated with lutetium PSMA 617. And then 1 of them had a partial thyroglobulin response from 17 to 9, but then progressed, and the other one did just progress. So very kind of preliminary results here. I would say, perhaps some potential benefit in a very selected cohort of patients, maybe an area of future interest to look at further in the future. Okay, so kind of closing in on the end of the lecture here to sort of summarize. So there's the key distinctions in imaging in general are the structural versus the functional imaging methods. For the anatomic imaging modalities, remember, ultrasound is the best first test for evaluating the neck in thyroid cancer patients. Additional roles for CT, MRI in treatment planning and as an adjunct for if the ultrasound is not answering the clinical question. Radioiodine imaging is important for RAI treatment planning, optimized with SPECT CT imaging for better localization. I do recommend the routine use of that technology if you have one at your institution. F18 FDG PET CT is useful for aggressive cancer variants and also in radioactive iodine refractory disease. And there are new technologies emerging for evaluating sodium iodide symporter, including iodine 124 PET or TFB PET. And then other targets, including PSMA and somatostatin receptors for other diseases. So that brings me to the conclusion of the lecture. I'd like to thank you very much for your attention. I'd be happy to take any questions from the audience.
Thank you, Dr. Flavell, for a wonderful talk. We have a question from Dr. Busaidi from MD Anderson. So first, she says it's a great review. So kudos to you. Can you discuss the utility of dotatate PET-CT in MDC and using Lutathera for therapy if positive?
That's a great question. Happy to talk about it. So dotatate PET-CT can be used in patients with medullary thyroid cancer. Of course, they do typically express somatostatin receptors. There is not a lot of data out there. It's really restricted to small case series. If you look at the published series in terms of selection or in terms of sensitivity, it seems that the sensitivity comparing FDG PET-CT against dotatate, maybe taking all patients maybe is kind of similar, although it's tough to really definitively conclude that. There again are some small case series of using Lutathera. So Lutathera is the lutetium 177 labeled version of dotatate. So it can be used for radionuclide therapy. Those are that has been looked at in a few small treatment series. We have not really done it at our institution. Based on my review of that literature, my feeling is that the outcomes for treatment with lutetium 177 dotatate in medullary thyroid cancer look a little less promising than they do in the gastroenteropancreatic neuroendocrine tumors, where it really is the standard of care. But that being said, it may work for some patients. So this is something that we again may on occasion discuss at our tumor board. I'm actually kind of curious to check it out. I hope I think it may actually work nicely in a properly selected subcohort of patients.
Okay. We have another question from Dr. Novello. Can you clarify why thyroid cancer expresses PSMA receptors?
Yeah,
that's a connection.
Yeah, absolutely. Great question. So yeah, you would think PSMA, right? Prostate specific. So it does turn out that PSMA it's not just expressed in prostate cancer, but it is expressed on the vascular endothelium on a variety of other types of cancers. Probably the one of these that is the most well known is clear cell renal cell cancer, but it turns out it is also expressed on the endothelium on some other cancers. So, and thyroid cancer does turn out to be one of them. So there have been a handful of publications demonstrating that including ours, that that PSMA can be used for imaging, and perhaps even as well for treatment of thyroid cancer in some cases.
Okay, one more question about I-124 PET-CT. So it's been around for a long time. It may be very useful to think to plan further treatments with radioiodine, to choose doses to use. So how come it's not in use? What's stopping it from being more commonly used in thyroid cancer patients?
That is a really great question. And, the common sense explanation would be that there is no reason why it shouldn't be used. And in my opinion is that, it should be used, that, it's the technologies we're using in some sense are outdated. However, the real life explanation is that the routine use of the technology requires, in at least the United States, requires approval by the U.S. Food and Drug Administration, and for, our insurance companies, et cetera, to reimburse it. Now, the problem is, and I've not been directly involved in any conversations with the FDA. So the conversations, as I understand it, is that they would look, in order for the FDA to approve the use of iodine-124 PET imaging, they would like to see some randomized, prospective sort of, or some not necessarily randomized, but some, higher quality prospective trials documenting the superior of the technology. The problem, of course, with that is that those trials are very expensive to run. So the challenge is, it's a little bit of a tragedy. In some sense, I think it's almost a trivial explanation, because it's literally the same molecule. You're just labeling it with a different isotope. But
right.
Yeah. So.
And is it expensive, the I-124?
Yes, it is. It is more expensive. Yeah.
Okay. One more question that we have. Some patients have PSMA PET-CT for other indications, and then you see thyroid nodule with an uptake. Does that mean the nodule is suspicious or not?
It would, it's a good question. So yes and no. So there are both benign and malignant thyroid nodules that will express PSMA in the vascular endothelium. So it is not a specific marker for malignancy. It should be, if that is encountered as an incidental finding on a PSMA PET exam, usually for a prostate cancer patient, the next step would be to get a thyroid ultrasound and work it up just like you would any other thyroid nodule.
So not like uptake on FDG PET-CT.
Yeah, that's a good question. In some sense, I do think the presence of the uptake does upgrade it compared to any thyroid nodule in general, but it's not like strongly predictive. And other, benign adenomas and things like that will have uptake of PSMA in some cases. So I wouldn't read too much into it. I think it upgrades it a little bit, but it's not like this is definitely cancer if it has PSMA uptake. Yeah.
Okay. So another question we have here. So if we don't use the I-124 PET-CT, is there an option, new methods of having a quantitative evaluation of the post-therapy scan, or I-123 whole body scans, quantitative evaluation, high uptake, low uptake, predict response to therapy? Do we have any new tools for that?
Yeah, it's a good question. So the challenge, so the iodine-124, the nice thing about PET is it's intrinsically quantitative, so it makes it easy to get that kind of dosimetry information, so you can at least understand the radiation dose you're administering. That is more challenging to do with the single photon emitting isotopes like iodine-131. There are people who are actually looking at this. We actually have a collaboration with a group at NCI looking at this, and there's some promise that perhaps even the single photon techniques could find some use in terms of looking at the absorbed dose for radiation, although from a physics perspective, and it's certainly a much more difficult problem.
Okay. We have a question from Dr. Camilo Gonzalez Valquez. First, he says it's a great review. So you discussed imaging in DTC, in differentiated thyroid cancer. However, what would you prefer as the imaging modality in patients with aggressive tumors, anaplastic tumors, poorly differentiated tumors before surgery?
Yeah, so pre-surgical, certainly, your diagnostic imaging of certainly you would want to get a CT scan of the neck with contrast, get a good, or alternatively MRI would be a reasonable alternative. And then in terms of whole body staging, so FDG PET CT is a good one. These are anaplastic, poorly differentiated tumors tend to be more aggressive tumors with a lot of FDG uptake. So that is, I would not recommend routine use of preoperative FDG PET CT for differentiated thyroid cancer, but for these poorly differentiated cancers, yes, I think it could be helpful to disclose distant mets.
And for example, for evaluation of the neck, would a CT scan or an MRI would be more indicative for invasion of for example, trachea, vessels, and things like that?
I think, that you might not get 100% concordance on the answer to that one, but I think probably most would say CT scan just in terms of for the precise localization invasion. But, MRI is a reasonable alternative as well. Yeah.
Okay. So the last question that we have before the hour ends, you didn't mention stunning. So this is something that people used to talk about a lot. You do a diagnostic scan and then you want to treat with radioiodine, whether the diagnostic scan would impair the radioiodine uptake. So how do you think of that, and how do you use the diagnostic scan before therapeutic dose?
Yep, that is a good question. So the presence of stunning, so what that means is that administering a diagnostic dose will somehow stun the uptake of the subsequent therapeutic dose and blunt the treatment response. So it is, I'll just say up front, that's a controversial topic, and depending on who you ask, some people may or may not even believe it exists. So that being said, so if you believe that it does exist, one way you can get away from it is, instead of using iodine 131, you can use iodine 123 because it's a lower dose, and it has a lesser probability of inducing stunning. So that's, again, is one of the potential benefits of using iodine 123.
Okay, so we've reached the end of the hour, and I want to thank everyone for being with us, and especially our speaker, Dr. Flavell, for an amazing talk and a great overview of the topic. Thank you.
Thank you very much for inviting me.
Bye.